Thank you everybody for coming. I want to talk a little bit about what colorectal surgery actually is. As we've heard, colon and rectal cancer is very common. The main primary treatment, or one of the main treatments, is surgery. That generally involves removing the part of the colon that has the cancer in it, and then generally joining the other two ends of bowel back together again. I think it's important to tell you all that this operation works very well for what it's designed to do. So of patients that are candidates for surgery, I guess what you would regard as cure, or in doctor speak, the cancer not coming back within 5 years or ever, is over 80%. So we do know how to get rid of cancer, in particular colon cancer. The outcomes are good from that point of view. The problem is that the surgery itself is quite morbid, particularly for elderly patients. It is major surgery. The bowel doesn't like to be handled or touched or resected. This has considerable implications, particularly in the short term after surgery. And for some patients, that can lead to loss of independence, which is a major problem in our field. So, we have opportunities to improve this. And so when we started thinking about what sort of research we wanted to do here, we asked ourselves, what are the things that patients ask us when we talk to them about bowel cancer surgery? And there's really three major themes. The first is, am I going to die of this cancer? Understandably. The second is, am I going to have a bag? Interestingly, those two questions are not necessarily in order of priority for some patients. And thirdly, how long is it going to be before I'm back to normal? When can I go back to work? When can I go back to my family? And so our research is targeted at answering these questions and improving the outcomes in these domains. There's a bit too much to talk about in 15 minutes, but I'll give you a sort of a snapshot in each one of these areas to familiarize you with the sort of work we're doing. The cancer question. Surgery does work well for bowel cancer. Bowel cancer is divided into 4 stages. The first 2 stages are very easily fixed with surgery. The third stage, which is where the cancer goes to the lymph nodes, which are lumps around the bowel, the success rate of surgery is a little bit lower. And with stage 4 cancer, the success of surgery is low. We've chosen to target stage 3 bowel cancer because we think that's where we have the most to gain from the clinical surgical research. The problem with lymph nodes in this area is that the diagnosis is difficult. So scans don't really tell us adequately whether somebody has positive lymph nodes or not. So unfortunately, what ends up happening is we have to take out the bowel cancer and the nodes, all of them, to figure out whether the nodes are positive or negative. And I think that can be improved upon. Secondly, if we did work out before surgery if the nodes were positive or negative, we're not sure what the best treatment in that situation is. Is it still surgery or potentially chemotherapy and radiotherapy? So we're trying to answer this question. We've partnered with the Australian Institute of Machine Learning, which is a tremendous resource available on the street. They are experts at using computers, artificial intelligence, to analyze scans. And this is the first time that they're looking at this particular kind of scan. So one of our research fellows, Sergei Bedrikovetsky, is currently busy downloading and annotating about 800 sets of CT scans in this area, and with the hope of training a computer-aided machine algorithm to tell us whether the nodes are positive or negative. I think the scans are good enough. I think the human eyeballs looking at the scans are where we fail, and therefore I think there's a lot of potential for artificial intelligence in this area. We haven't stopped there, so we're already working on the question of what do we do when we know the nodes are positive. There are a few centers in the world that are particularly interested in this question in rectal cancer. A mentor of mine at MD Anderson, George Chang, as well as Miranda Kusters in Holland. We've already analyzed all of our data, including the Royal Adelaide Hospital's data, and we can say with a couple of publications already out and one coming soon that it is not enough to remove the lymph nodes in rectal cancer. Radiation plus surgery is probably where it's at, and it's important to say that's not what we do currently here or in most of Australia. So I think this will be a practice-changing discovery in the next few months to years. So better diagnosis is coming and better treatment is coming, and I think with both of these modalities we will considerably move the needle on stage 3 colorectal cancer in the near future. What about the next question? Do I need a bag? This is a picture of that joint in the bowel. That white line are staples between 2 loops of bowel. In this patient, this joint has not healed, and that has resulted in what's called an anastomotic leak. Those little spots are air outside the bowel where they don't belong, and all that fluid is bowel content leaking out of this joint. This causes peritonitis and is quite a major problem for patients when it happens. Fortunately, it's not that common. We call this an anastomotic leak, and it's probably the scariest complication after colorectal surgery. This seminal paper from Spain was published a few years ago where they looked at a large number of patients and identified independent predictors of who's going to leak and who is not going to leak. The problem with this paper is that the findings were presented in a very old-fashioned way, an old-fashioned nomogram that required the surgeon or the patient to bust out a ruler, line up various lines on a piece of paper, and then work out what their leak rate is. The process took about between 5 and 10 minutes per patient and was sort of impractical. So we fixed it. We turned it into a very simple online calculator that we can use, and we then validated this calculator on our patients. So we've had a couple of publications from this, and basically what it shows is that this calculator does predict who's going to leak in the Royal Adelaide Hospital, as it did in Spain. We didn't stop there. We then went, well, okay, so the calculator works, but is it better than the surgeon? So we did a head-to-head blinded comparison between the operating surgeon's estimate of leak versus the calculator. Don't worry too much about the specifics of this chart, but what you need to know is the further the line away is from the middle line, the better the test. The surgeon's estimate was essentially useless to figure out whether this patient was going to leak or not. Because it relied a lot on what the surgeon perceived to be technical aspects of the surgery, when in reality that's probably not the main thing that causes leak. Alternatively, the calculator was actually quite predictive. So we use this in practice, or at least I do. But what about intraoperative variables? Are there things that happen during the operation that affect the leak rate? And so we joined an international collaboration. Hira Kroon, one of our other research fellows, who's Dutch, translated this Dutch study to English, which allowed us to join the group. A large number of patients, mostly from Europe, with one center from Australia, which is the Royal Adelaide Hospital. And we looked at intraoperative factors that could affect an anastomotic leak. Overall, the leak rate in this cohort was 7.9%, which is about the sort of industry average, if you want to use that term. Don't worry about the numbers. In fact, I'll get rid of all the numbers. What you need to know is that there were 4 intraoperative variables out of a huge number that were assessed prospectively that impacted whether patients had a leak or not. And those were low blood count, low blood sugar, whether they had an epidural or not, and whether they had hypothermia or low temperature on the table. And in fact, the more of these things that happened, the astronomically higher the leak rate became. If they had more than 1, 2 or more, the leak rate was over 30%. And these are just intraoperative variables during the surgery. So as far as do I need a bag or not, I can say that in 2019 at the Royal Adelaide Hospital, we can predict someone's anastomotic leak rate with a certain level of reliability. What we need to do is use this information, and at the moment we're not really using it adequately. I think we can use this information to improve selection. Do you want this operation, knowing that you have a 40% chance of having peritonitis? Would you rather have something else like chemotherapy? Would you want the surgery and not have a joint? In other words, commit to a bag up front? All of these questions need to be answered still. And also, can we affect the leak rate? So we know what causes the leak rate. Can we change any of these things to reduce the leak rate? And that's the subject of an upcoming study, again, collaborating with our Dutch colleagues, and that we're hoping will start next year, where we'll actually institute a change during surgery and see if that affects the leak rate. So the third question, recovery. The truth is, the thing that keeps people in hospital the most after colorectal surgery is waiting for the bowel to get going. In a certain percentage of the people, the bowel does not get going, and that's about, in the Royal Adelaide, upwards of 30%, where what's called an ileus happens. This is another scan showing this, so the bowel is dilated, it's full of fluid, and it's not pushing anything through. This is a very common problem. It's the most common single complication after bowel surgery. It has not got the attention that it deserves, and we're hoping to address that. So what patients experience when they have an ileus is they feel bloated, they vomit, and the bowels aren't working. Importantly, it is strongly associated with other complications, particularly pneumonia, because elderly patients who vomit tend to aspirate. And in fact, the single most common cause of death after elective colorectal surgery is ileus and aspiration pneumonia. It's also not fun to be nauseated non-stop for several days on end. So what do we currently do about ileus? And the answer is we don't do anything. We put a nose tube in, essentially a sump, siphoning off the fluid onto the floor, into a bag on the floor, and we wait. That's all we do. And this management has not changed for decades, and in my opinion is unacceptable. And so we're hoping to address that. The first thing we want to do, unlike leak, we don't actually have a lot of information as to why ileus happens and what the risk factors are. So we hope to fix this. We then want to trial simple laxatives preemptively to try and stop the bowel going to sleep. That has not really been done for some reason. And then thirdly, once we've established the baseline, trial some novel therapies. This was a massive study that we joined, led by surgical registrars, but also Adelaide University medical students, and they've been extremely helpful in running this study. This study recruited upwards over 4,000 patients in 6 weeks in lots of different hospitals, quite a few in Australia, Queen Elizabeth and Royal Adelaide in South Australia. What this study showed importantly, and has resulted in a change in practice, is that the amount of opiate, in other words, morphine and fentanyl drugs that patients needed after surgery was directly correlated to how slow the gut was to get going. And as a result of this and other similar studies, we have instituted an opiate minimization protocol after colorectal surgery. And we've been successful at dramatically cutting the amount of opiates people use by using other non-sedating and non-ileus causing drugs instead. The Stimulax trial. This is probably the centerpiece of our research. Dr. Nagendra Durivenkata is doing a PhD at the moment, and he is running this trial. It's a randomized controlled trial where patients in the study arm are being given preemptively coloxalin, senna, Movicol, and a fleet enema if they're not having rectal cancer surgery. And the standard care arm is what we currently do, which is not much, normal routine care. This study started a year ago, only at the Royal Adelaide. We've recruited over 100 patients, and because the study is not blinded, we can report that in the first 100 patients or 110 patients, there has been a 2-day hospital reduction as a result of this. Now, we can't really comment on whether this will continue, but it's looking like it's trending towards quite a dramatic result. The study will be finished probably towards the end of this year or early next year, and we'll have some permanent convincing results then, I hope. Once we establish this and we know what our patient profile is and if the laxatives work, start giving them, we then hope to test some novel drugs. We have a lot of quite exciting candidates, one in particular that we will be submitting an ethics application for in the next few months. Unfortunately, I can't tell you what the drug is, but it will maybe at the Behind the Microscope next year, I'll let you know. So that's the stuff that we're doing internally, but there are a whole bunch of studies. We sort of collaborate a lot internationally. This is a smorgasbord of studies that are either finished or currently in recruitment, mostly led by overseas investigators that we're joining. If you want more information on this, go to colorectalresearch.org. That's our website, and it'll tell you information about each of the studies, in particular the international ones. I would like to thank the patients, first and foremost, who have contributed to these studies. Obviously, CALN and the Royal Adelaide Hospital Research Fund, who have been instrumental in allowing us to perform the studies that we want to perform. I want to thank my family, who have made it out to support me today, so thank you for coming. And obviously, all the members of the research team, the Colorectal Research Group. I don't really do anything, to be honest. I just steer the ship. They do all the hard work. And the doctors and nurses on the ward, our head of unit, Michelle Thomas, they're the ones who make this possible. I'm just sort of the person who sits up here and takes all the credit. Thank you.
So we'll have a bit of a discussion now, and I'll just sort of warm things up, and then we'll invite questions from the audience. And I have a few submitted questions already. But sort of one of the things that occurred to me as you were talking, clearly the sort of work that you're doing with patients as opposed to tissue culture cells in a dish is you have the opportunity to investigate those human factors. And you talked about how people are anxious about having the colostomy bag and so forth. So I wondered, from a research perspective, how do you scientifically analyse patient quality of life and outcomes, and how does that feature in the work you do?
That's a very good question. I think you've touched on an important topic here. I don't think it's enough anymore to just measure what doctors care about. I think it's important to measure what patients care about and what they experience. All of our trials that we prospectively enroll patients in have an element of patient contribution. So for example, for the Stimulax trial, we have a scale called the Surgical Recovery Scale, which is something that I worked on when I was doing my PhD. Basically, it's a validated measurement of quality of life, but it's very short, and it's easy for patients to fill out. The problem with a lot of the traditional quality of life metrics is it involves about 35 questions, and it needs to be done over and over again. And if you've had major bowel cancer surgery and you get given a 5-page document with 35 questions, half of which aren't relevant to you, it can become very difficult to and not relatable to the patients to fill that out. And so as part of my previous life, we validated a 7-item score that attempts to capture the patient experience beyond things like survival and complications. And so we make it a point to work that into all of our research protocols.
Yeah, very good. And obviously, if we were able to detect bowel cancer earlier, the surgery would be easier. And we've all heard about the cancer screening programs and so forth. I wonder if you could tell us from your experience how many of these cancers that you're dealing with potentially might have been picked up earlier. I mean, how well is this screening program working?
Yeah, so we have some information on that. So the compliance with the screening program, so if you're between the two limits of the screening age, is only about 40%. So we miss out about 60% of patients that are candidates for screening that never submit the test. In the 40% that submit the test, there is significant downstaging of tumors that are picked up. But also importantly, bowel cancer usually starts as a polyp, and the polyp is typically removable without surgery. What we don't have a sense of is, of all these polyps that we're removing in the screening program, how many would have ended up becoming a cancer? That part is unanswered. But I can say with confidence that the Australian National Bowel Cancer Screening Program definitely downstages colorectal cancer. And we know that because patients that turn up with symptoms, when we compare that to the screened population, there's quite a significant difference in the stage 1 to 4 that I talked about earlier. A lot of the patients in the screening program are downstage to stage 1 and 2 cancer.
Very good.
As to a figure, maybe 30%. Yeah.
So obviously you're a busy practicing clinician and surgeon, and like most of us, we're running around just trying to look after patients all the time. How do you manage to balance the time between the actual research that you're trying to organise and the clinical care?
Yeah, to be honest, I think I'm lucky here because my appointment here a few years ago was based on this idea that I would have dedicated research time. Because otherwise, most surgeons do not have the time between the public and the private sector to do anything in terms of research. And so I have sort of designed my week around the idea that I have protected time to undertake research, and that is a testament to this institution and the colorectal unit at the Royal Adelaide Hospital, as well as the University of Adelaide, that I can do that. There are a lot of places in the world where that sort of arrangement is not possible.
This is a bit of a Dorothy Dixer, but would you say this opportunity to do clinical research is actually an essential part of what a university hospital should be doing? Yeah,
well, I mean, as was mentioned before, I don't really think quality care can be delivered in a hospital without quality research alongside it, because what tends to happen is a general drift towards the lowest common denominator in terms of practice. And that's because things that are easy aren't necessarily things that are good for patients. And without the scientific element continuously challenging us to move forward and to maintain standards, I think things tend to go the other way.
Sure. I've got some more submitted questions from the audience here. Basically, because we were talking about the technical aspects of the surgery as well, and one of the questions is focused more on the lower rectal surgery and what advances are there technically in preserving the anus and that sort of thing, so people presumably ultimately don't have to have a colostomy bag. Where is that heading?
I think it's a very good question. It is the sharp end of the stick when it comes to colorectal surgery. So rectal cancer surgery in particular is much more complicated, and the quality of life implications are definitely more dramatic in terms of the impact on the patient of the operation. I think the question was focused on, are there any technical surgical things we can do to improve continence and sphincter preservation after surgery? I don't think there is. However, I think the major advance in rectal cancer has been avoiding surgery entirely. And I think there will be a time in the near future where a significant proportion of patients with rectal cancer will have radiation and chemotherapy and not require surgery. Currently, our rates of what we call a complete response, which is where you have radiation and chemotherapy and then the cancer is gone, are in the sort of low double digits, maybe just under 20%. We are actually submitted an ethics application recently for the Royal Adelaide Hospital to move the post-operative chemotherapy forwards to give it before surgery, Because if you do that, the rates of a complete response go up to about 40 to 45%. I think your best bet in terms of preserving continence with rectal cancer is not to have an operation. And I think if we can get to the point where patients do not require surgery and do not require their rectum and their sphincters removed, then in terms of function, I think that'll be a lot better going forward. And I think that's where we're going with this.
And I guess that, again, points out the importance of early detection and perhaps getting on board with the screening. There's been a lot of press in recent times, and the audience probably heard about immunotherapy, which is drugs that switch on the immune system in various cancers. Is that something that's happening in colorectal cancer at the moment?
It is. The success with colorectal cancer has been a lot lower than with what's called solid organ malignancies or solid tumors. Where I was working at MD Anderson, they had a whole bunch of immunotherapy drugs they were trialing. It doesn't work very well for colorectal cancer, with the exception of a small subgroup of patients that have a particular genetic mutation. In those patients, the results can be absolutely dramatic. The thing about immunotherapy, unlike traditional chemotherapy agents, is that when it works spectacularly. Unfortunately, that only applies to about 5% or so of colorectal cancer patients where these drugs will actually make a considerable impact. That's not to say that the next generation won't be better, but the current generation are basically reserved for a small subset with a particular specific mutation.
And is that detection of that mutation something that is routine?
Correct. Well, in this hospital it is. Yeah. It's not nationally and worldwide, but at the Royal Adelaide Hospital, every patient that has a bowel cancer operation or a biopsy of a bowel cancer is tested for this panel or this type of mutation.
All right. A couple of other questions from the audience. One is the perception that colorectal cancer is becoming more prevalent in younger demographics. And a related question, is there any behavioural modifications that you can do, good diet, exercise, etc., that people might be able to adopt to avoid or reduce their risk of getting bowel cancer?
The rate of colorectal cancer in younger populations is increasing in the Western world. The data from Europe, the US, and Australia and New Zealand is consistent in that regard. How much of that is biology and how much of it is better detection is unclear, but the suspicion is that it has something to do with some sort of environmental factor that's causing it. We know what, in terms of dietary exposure, what increases your risk of bowel cancer. Smoked and processed meat, smoking, and alcohol, and obesity are the big ones. However, having said that, if you were to remove all of these dietary influences, the rate of bowel cancer is not going to go down to zero. The estimated impact of nature versus nurture is approximately 30%. In terms of, so if you led a perfectly fit and healthy lifestyle and avoided the carcinogens, you'd probably reduce your risk compared to somebody who does not by about 30%. But I suspect that won't necessarily mean that the rates of bowel cancer will plummet dramatically. And to be honest, I think it is somewhat unrealistic to expect that we will treat this disease with dietary modification and exercise alone. That's just one component.
Okay. Now, someone's been reading a book called The Immortal Life of Henrietta Lacks, which is a woman from whom cells were taken from, she had cervical cancer of the cervix, and then they were grown in the laboratory and really opened the field of tissue culture in laboratories to look at cells. And the question was, are these particular cells being used? I mean, I can say I've used them for some of my gene therapy studies, but just because the question's asked, is that?
Yeah, we don't do any basic science research in our group. We do collaborate with the Sammour colorectal cancer group quite a bit. They lead the studies, and they don't do as much cell line work, but they do a lot of organoid work where the cells from the individual patient that we're treating are grown in the lab and cultured in that way. And the reason it's like that is because in the era of personalized therapy, the application of other cell lines to current patients is not as strong as perhaps growing the individual patient's cells. And so a lot of our research that we collaborate with Sammour on involves individual Royal Adelaide patients' tissue rather than external tissue cell lines. Personally, I'm not a lead investigator on any basic science research. Our focus is largely clinical research.
Sure. Someone's asked, what are the prospects for research in South Australia compared to the eastern states? And I guess we've heard what you're doing.
Yeah.
Where does South Australia sit in the national
Well,
study?
I can mainly comment on colorectal surgery. In terms of clinical research, I think we're up there. And the reason I think that is because what we have here, which is relatively unique, is a fairly closely knit population, not just of patients, but of doctors. So, there are 4 main colorectal surgical hospitals in South Australia and Adelaide. There is excellent collegial working relationship between all these different units, and all in close proximity, dealing with a population for South Australia, but also up and down the corridor. So in terms of output, research output, and perhaps, I guess, clinical workloads, per unit, I would say we punch well above our weight in terms of that. I can confidently say that, when I say look at Victoria or New South Wales, each individual, there are a lot more hospitals, but each individual hospital is similar size or smaller than the Royal Adelaide. And because of the issues with the number of hospitals and perhaps less easy access between the different facilities, the ability to undertake clinical research is not as strong. And to be frank, one of the reasons we've joined international trials is because we've struggled to find national trials to join. And so we are either creating our own or joining international studies for that reason.
And how important would you say the RAH Research Fund and its activities are for your work in particular?
It's crucial. I mean, it's not just, obviously the donations are welcome, but it's not just about that. I think it's a meeting of like minds. The engagement of the staff of the Royal Adelaide Hospital Research Fund and the patients, the donors, in the research that's conducted on them and their neighbors and their friends and family is a very important part of how we are able to function the way we function. And I think that spirit of, we should be doing research to help the citizens of South Australia and to create new evidence for the rest of the world is absolutely crucial. And I think the RA Research Fund and CAL in particular and the University of Adelaide embody that spirit, and it allows us to do the work that we do.
And do most patients that come through your unit have the opportunity to be involved in one or other of the research projects at the moment?
Yeah, so pretty much anybody having a bowel cancer operation. Unfortunately, at the moment, in fact, there's too many studies, and so I wanted to thank the patients, if any of them are here, for putting up with it. I mean, a lot of the times our patients are being consented for 4 or 5 different studies, and we're quite careful not to overlap studies that are, that are interfering with each other. But between SAMRI, the anesthetic department here, which is very active, and our group, most colorectal cancer patients are candidates for 5 or 6 studies.